By the time the cell door opened, the damage had already been done. Medical staff were called in under escort, moving quickly through layers of steel and procedure. Every second counted, but nothing inside these walls ever moves without clearance. The patient had reported symptoms days earlier. Requests were logged, reviewed, screened, and prioritized against security risk. In a place built for control, urgency competes with protocol. And sometimes, protocol wins. Treatment inside extreme security facilities does not begin with medicine. It begins with authorization. Access depends on classification, staffing levels, threat assessments, and the constant calculation of risk versus care. What happens when healthcare must operate inside a system designed first for containment? Before we continue, subscribe for more documentary. Inside facilities such as ADX Florence in Colorado, healthcare functions under some of the strictest security measures in the United States federal prison system. Movement is controlled, communication is monitored, and contact is minimized. The institution is known as the Administrative Maximum Facility, operated by the Federal Bureau of Prisons. It houses inmates considered the highest security risks, including terrorism convicts and violent offenders. Medical services at facilities like this are technically governed by the same constitutional standard applied nationwide. Inmates are entitled to adequate medical care under established Supreme Court precedent. That standard originates from the principle that deliberate indifference to serious medical needs violates the Eighth Amendment. But translating that principle into daily practice inside a supermax facility is complex. Every clinical interaction begins with a security assessment. Before a nurse enters a unit, correctional officers evaluate risk level, restraint requirements, and escort protocols. In many cases, inmates are handcuffed through a food slot or placed in restraints before medical staff can conduct even a basic examination. Direct physical contact is often limited. This restriction affects diagnostic procedures. Routine tasks like taking blood pressure, listening to lung sounds, or checking for injury may require modified techniques to accommodate barriers. But the restrictions do not end with physical examinations. Medication distribution also follows strict procedures designed to prevent misuse, diversion, or weaponization. Prescriptions are typically dispensed through controlled medication lines. Pills may be crushed or provided in liquid form to prevent hoarding or trafficking between cells. Even something as simple as an inhaler can become a controlled item. Staff must account for every device issued and ensure it cannot be altered or repurposed. Emergencies introduce additional layers of tension. When an inmate reports chest pain or severe distress, officers must verify the situation before initiating movement protocols. Cells are not opened immediately. Staff must assemble response teams, apply restraints, and secure surrounding areas before medical personnel are permitted direct access. This delay is not designed to deny care. It reflects the institutional priority placed on maintaining order and preventing coordinated disruptions. Yet the balance between caution and speed has been questioned in lawsuits and oversight reports. Critics argue that bureaucratic delay can increase medical risk. Federal prisons, including high-security institutions, operate under internal policy guidelines established by the Bureau of Prisons Health Services Division. These policies outline standards for chronic care clinics, mental health evaluations, emergency response, and medication management across all federal facilities. However, implementation varies depending on staffing levels, facility design, and inmate classification. In supermax units, the physical layout itself shapes healthcare delivery. Most inmates are housed in single cells for approximately 23 hours per day. Medical staff often conduct initial assessments through reinforced doors rather than inside rooms. Communication barriers complicate evaluation. Symptoms are described through narrow openings, sometimes with limited visibility and no direct physical examination. For chronic conditions like diabetes, hypertension, or asthma, this structure requires careful scheduling and frequent monitoring within restricted time windows. Inmates requiring outside hospitalization must undergo extensive transfer procedures. Transportation involves armed escorts, secured vehicles, and coordination with external medical centers. These transfers are resource-intensive and tightly controlled. Not every request results in outside treatment unless deemed medically necessary by prison clinicians. Mental health care presents additional complexity. Many high-security inmates are housed in conditions of extended isolation, which can affect psychological stability. Psychologists and psychiatrists conduct evaluations within security frameworks that limit group therapy and restrict in-person interaction time. Suicide prevention protocols include regular welfare checks and monitoring, yet critics have argued that isolation itself may exacerbate mental health conditions. Court filings in various federal cases have challenged whether supermax confinement conditions complicate adequate mental health care delivery. The Bureau of Prisons has responded by citing expanded mental health services and structured monitoring systems within high-security facilities. But oversight reports have periodically highlighted staffing shortages across federal prisons, raising questions about consistency of care. Recruiting licensed medical professionals to work inside maximum security environments presents practical difficulties. The setting demands both clinical expertise and security awareness. Medical personnel must complete background checks and security training before beginning work. Their role requires constant coordination with correctional officers. Every appointment is effectively a joint operation between healthcare and security teams. Clinical judgment must operate within institutional constraints. Documentation also becomes a critical safeguard. Detailed records are maintained to demonstrate compliance with constitutional care standards. These records can later become central evidence in litigation if inmates allege inadequate treatment or deliberate indifference. And in this environment, where every action is logged and scrutinized, even routine medical decisions carry potential legal consequences. But documentation alone cannot resolve the underlying tension between security and medicine. That tension remains embedded in daily operations. Few outside the system ever see how those two priorities collide in real time. Healthcare inside extreme security facilities does not pause for routine. Every request for care begins with paperwork, classification review, and an evaluation of potential institutional risk. Inmates typically submit written requests known as sick call forms. These forms are collected, reviewed by medical staff, and triaged based on urgency and reported symptoms. But triage in this setting involves more than medical judgment. Staff must also consider behavioral history, disciplinary status, and potential manipulation of the system. Some inmates have histories of using medical complaints to facilitate movement outside restrictive housing. That reality shapes how staff interpret repeated or vague reports. Yet medical professionals are required to distinguish between strategic behavior and legitimate illness. Failure to do so can carry serious constitutional implications. If a condition is deemed urgent, correctional officers coordinate the movement process. The inmate is restrained, escorted, and positioned for evaluation under supervision. Even during examination, physical positioning may be restricted. Waist chains, handcuffs, and leg irons can limit access to parts of the body. This affects how clinicians assess injuries or chronic pain complaints. Standard examination techniques are sometimes modified to fit security protocols. Dental care follows similar constraints. Instruments are carefully inventoried before and after each appointment to prevent misuse or concealment. Sharp tools are counted repeatedly. Access to even basic dental procedures requires layered oversight between custody staff and clinical providers. Chronic disease management clinics operate on structured schedules. Inmates with ongoing conditions are seen periodically according to institutional guidelines. Blood draws, laboratory testing, and vital sign monitoring must be completed within narrow windows of movement authorization. Laboratory samples are processed either within prison facilities or transported externally under secure chain of custody procedures. The chain of custody requirement extends beyond evidence. It applies to medical materials, equipment, and sometimes even biological specimens. Specialty consultations introduce additional complexity. Outside cardiologists, neurologists, or surgeons cannot simply enter high-security housing units without clearance. Telemedicine has become one tool to reduce movement risk. Secure video platforms allow specialists to evaluate patients remotely. But telemedicine has limitations. Certain diagnostic procedures cannot be performed without physical examination or advanced imaging equipment. When imaging such as MRI or CT scans is required, inmates may be transported under heavy guard to community hospitals. These transports can involve multiple vehicles and coordination with local law enforcement agencies. Every external visit increases operational cost and security exposure. Decisions to authorize transfer are therefore weighed carefully. Cost considerations are not the primary factor under constitutional law. Medical necessity remains the guiding legal standard. However, resource allocation influences scheduling and prioritization. Federal prisons operate within annual budgets approved by Congress. Budget constraints have periodically led to staffing shortages across facilities, including medical departments. When vacancies exist, appointment backlogs can grow. Delays may extend routine follow-ups beyond ideal timelines. Oversight bodies have documented instances where limited staffing contributed to slower response times. The Bureau of Prisons has publicly acknowledged workforce challenges and initiated recruitment efforts in recent years. Even with recruitment campaigns, retention remains difficult in remote or high-stress environments. Medical professionals working inside supermax settings operate in controlled spaces where alarms, lockdowns, and security alerts can interrupt clinical flow. A facility-wide lockdown can suspend non-emergency appointments entirely. During lockdown periods, only urgent or emergent cases receive attention, often through cell-front assessments. Cell-front care limits privacy. Sensitive discussions occur within earshot of security personnel. Confidentiality is legally required, yet practical realities reduce the degree of privacy available. Mental health services face particularly complex obstacles under extreme security. Inmates in restrictive housing often receive individual sessions conducted through secure doors or in specialized interview rooms. Group therapy is rarely feasible in the highest security units due to safety concerns. Psychotropic medication management follows similar controlled distribution protocols as other prescriptions. Mental health staff must monitor for signs of decompensation, self-harm risk, or behavioral escalation. Suicide prevention protocols involve layered monitoring, including periodic wellness checks and mental health evaluations. When an inmate expresses suicidal intent, crisis intervention measures are activated. These measures may include placement in observation cells designed to reduce self-harm opportunities. Observation units are themselves subject to criticism, as isolation can intensify psychological distress. Federal courts have reviewed claims related to mental health care adequacy in high-security environments. Judicial decisions have consistently affirmed that inmates retain a right to meaningful access to care. But courts also recognize the deference given to prison administrators in matters of security. This legal balance creates a narrow corridor in which healthcare must function. If staff respond too slowly, they risk constitutional violation. If they move too quickly without security clearance, they risk institutional safety. That tension defines daily practice inside facilities built primarily for control. Few healthcare systems in the country operate under comparable structural restrictions. And yet, the expectation remains unchanged. Care must meet constitutional standards. The question is not whether healthcare exists inside these walls. The deeper question is whether it can fully function when every decision passes first through security. Oversight does not end with internal review. External watchdogs, inspectors, and federal courts periodically examine how healthcare functions inside high-security institutions. The Department of Justice Office of the Inspector General has released reports evaluating medical staffing levels and response systems across federal facilities. These reviews often focus on delays, vacancy rates, and compliance with established clinical protocols. When deficiencies are identified, corrective action plans are typically implemented under centralized Bureau of Prison supervision. But reform inside extreme security settings moves gradually, shaped by operational realities. Litigation has played a significant role in defining healthcare expectations behind bars. Inmates who allege inadequate treatment may file administrative grievances before seeking relief in federal court. The grievance process itself is structured and time-sensitive, requiring multiple levels of review before external litigation proceeds. Medical records frequently become central evidence in these disputes. Courts examine documentation to determine whether providers acted with deliberate indifference or exercised reasonable clinical judgment. Deliberate indifference is a high legal threshold. It requires proof that officials knowingly disregarded a substantial risk to health or safety. Most cases hinge on whether delays were intentional neglect or constrained responses shaped by institutional policy. Judges must weigh security considerations against constitutional protections. This balancing act has defined prison healthcare jurisprudence for decades. Meanwhile, inside the facilities, daily operations continue regardless of litigation. New inmates arrive with complex medical histories. Some enter with chronic illnesses requiring immediate stabilization. Others present with mental health diagnoses that predate incarceration. Intake screening is the first critical step. Medical staff conduct initial assessments to identify urgent needs and medication continuity requirements. Disruption in prescribed medication can create rapid deterioration. Ensuring continuity depends on verifying outside prescriptions and coordinating secure distribution. Verification can take time, particularly if prior providers are difficult to reach. During that window, clinicians must make provisional decisions based on available information. These decisions carry consequences. An incorrect dosage or delayed renewal can escalate medical risk. But accelerated action without confirmation can create other liabilities. The system is built to prevent error, yet it cannot eliminate uncertainty. Technology has gradually changed aspects of prison healthcare. Electronic health records now centralize documentation across federal institutions. This allows providers to review histories even if an inmate transfers between facilities. Transfers are common within the federal system. Each transfer requires medical clearance before movement. Clearance includes reviewing stability, medication needs, and special accommodations. A medically unstable inmate cannot be transported without planning. Ambulances may be used when necessary, accompanied by armed escorts. Security and healthcare planning intersect at every stage. Even diet can become a medical issue. Special therapeutic diets must be approved and coordinated with food service departments. Requests for modified meals are reviewed carefully to prevent misuse. Yet for inmates with conditions like diabetes or hypertension, diet compliance is clinically important. Access to exercise also influences health outcomes. In high-security housing, recreation time is limited and tightly scheduled. Physical inactivity can contribute to worsening chronic disease. Medical staff document these realities, but cannot independently alter housing design. Facility architecture shapes health in ways that medicine alone cannot correct. Isolation, limited sunlight, and restricted movement affect both physical and mental well-being. Research on prolonged isolation has raised concerns among public health experts. Federal officials maintain that structured monitoring mitigates those risks. Monitoring, however, does not eliminate environmental constraints. Ultimately, healthcare inside extreme security institutions operates within a closed system. Every diagnosis, prescription, and referral must align with operational control. The constitutional mandate remains constant despite those limits. Adequate care is not optional under federal law. But adequacy is interpreted through the lens of security necessity. This is the central tension that defines supermax medicine. When a medical emergency unfolds, staff respond through rehearsed protocols. Alarms sound, teams assemble, restraints are applied, and treatment begins. Afterward, reports are written and timelines reviewed. Each event becomes part of an institutional record. Those records shape policy revisions and training updates. They also shape public understanding when released through oversight processes. Most of this work remains unseen by the outside world. Healthcare under extreme security is neither fully autonomous nor entirely restricted. It exists in negotiation with its surroundings. And that negotiation continues every single day. If this story kept you watching, the next one will stay with you even longer. Subscribe for more real prison documentaries. Despite layers of restriction, healthcare staff inside extreme security institutions describe their work as fundamentally clinical, not political. Their responsibility is to treat conditions within the boundaries imposed around them. Many providers report that the challenge is not unwillingness to deliver care, but navigating procedures that slow ordinary medical response. Every step requires coordination with personnel trained for control, not treatment. Training programs attempt to bridge that divide. Medical employees receive orientation on security awareness, while correctional officers receive limited exposure to healthcare protocols and emergency response basics. Still, the cultures remain distinct. Security prioritizes predictability and containment, while medicine prioritizes responsiveness and individualized judgment. When those priorities align, operations proceed smoothly. When they conflict, decisions become complicated and heavily documented. Consider the management of aging populations inside high-security settings. Federal prisons have experienced a steady increase in older inmates with chronic and degenerative conditions. Aging brings higher rates of cardiovascular disease, mobility impairment, and cognitive decline. These realities create demands that supermax architecture was never designed to accommodate. Wheelchairs, walkers, and assistive devices must be reviewed for security compliance before approval. Even medical accommodations undergo risk assessment before implementation. Special housing considerations may be necessary for inmates with significant medical fragility. Yet transfers to lower security facilities depend on classification review, not solely medical recommendation. That review weighs behavior history, sentence status, and threat designation alongside clinical need. Compassionate release mechanisms exist under federal law for certain terminal or severely debilitated inmates. Applications for such release require medical documentation and administrative approval through multiple levels of review. Approval is not automatic. Decisions consider public safety, legal standards, and institutional policy. Meanwhile, healthcare continues inside the facility regardless of release outcomes. Infectious disease management represents another operational challenge. Outbreak prevention relies on screening, vaccination programs, and isolation procedures when necessary. Isolation for medical reasons differs from disciplinary segregation, but the environments may appear similar. Medical isolation units are monitored for symptom progression and recovery benchmarks. During national public health emergencies, such as the COVID-19 pandemic, federal prisons implemented testing, quarantine, and vaccination campaigns. High-security facilities faced the additional difficulty of conducting large-scale health interventions within already restricted movement patterns. Testing required coordination between healthcare teams and custody staff to ensure orderly sequencing. Vaccination clinics operated under escort protocols and careful inventory control for medical supplies. Public reporting on infection rates and mortality within federal institutions increased external scrutiny. Transparency became part of institutional response, alongside internal mitigation strategies. Yet, even during crisis response, the baseline structure of extreme security remained intact. Healthcare providers adapted workflows without dismantling containment systems. This adaptation required extended shifts, revised scheduling, and constant procedural updates. Burnout among correctional healthcare workers has been documented in academic research. High-stress environments, staffing gaps, and exposure to complex behavioral dynamics contribute to fatigue. Retention strategies include incentive pay, mental health support for staff, and structured rotation assignments. Despite pressures, many providers remain long-term. Some cite professional commitment to underserved populations as motivation. Others describe the work as uniquely challenging but meaningful within constitutional boundaries. Constitutional standards continue to frame every evaluation. The Eighth Amendment obligation does not fluctuate based on facility type. Courts have reiterated that incarceration does not eliminate the state's duty to provide adequate medical care. Adequacy, however, is interpreted within the operational context of secure confinement. That context shapes how quickly a provider can respond, how freely an inmate can move, and how privately care can be delivered. Critics argue that structural limits inherently compromise healthcare quality. Federal officials counter that structured systems preserve both safety and constitutional compliance. Independent assessments fall somewhere between those positions. Reports acknowledge improvement efforts while noting persistent logistical constraints. In the end, healthcare under extreme security is defined by constant negotiation. Medicine advances through protocols filtered by steel doors and layered authorization. Every examination, prescription, and emergency response unfolds within that framework. The public rarely sees these interactions. They occur behind reinforced walls, documented in clinical notes rather than headlines. Yet they represent a daily test of whether constitutional guarantees can operate inside the nation's most restrictive institutions. The outcome of that test is measured quietly, case by case. Sometimes it results in stabilization and recovery. Other times, it leads to litigation, policy revision, or institutional review. What remains consistent is the requirement that care exist, even in places designed primarily for control. Healthcare in extreme security facilities does not operate freely. It operates deliberately, cautiously, and under watch. And within those limits, it continues every day. If this story kept you watching, the next one will stay with you even longer. Subscribe for more real prison documentaries.